Welcome to Caring
Welcome to Caring Well.
Welcome to Caring
Welcome
Well.
to Caring
Welcome
Well.
to Caring Well. Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well, a Middleton Pediatrics podcast. Here we have conversations about topics that may not get talked about at the typical pediatric office visit, but are so important to helping your child flourish. Today, we have a conversation with Dr. Alejandro Jordan, the pediatric infectious disease doctor at Orlando Health. So let's jump to that conversation. Dr. Alejandro Jordan, welcome back.
Thank you.
It's been a while although we talk a lot, it's been a while for you to be on our podcast. And so really appreciate you coming back. A lot of different things I want to talk about just as a way of reintroducing you.
Mm-hmm.
Pediatric infectious disease doctor with Orlando Health.
Correct.
Give me a little bit of your journey into pediatric infectious disease, kind of why, where, all that.
I didn't want to do it initially. So I'm from Colombia. And in Colombia, medicine is a 7-year program. So it's different than here. So we don't go to college or pre-med and then we the test and we do 4 years of medicine. In Colombia, you finish high school and you go directly into medicine. And it's a 7-year program. And after that, you finish, you have to work in an underserved area to be able to get your license to work. So our internship is the last year of medicine, different than here that the internship is the first year of residency. So we are allowed to go and do that internship in somewhere else. So I decided to come to the United States and do it, and I did it at University of Connecticut. But up to my 6th year of medicine, I wanted to do adult GI. I didn't want to do pediatrics, and I wanted to do infectious diseases, nothing like that. But in University of Connecticut was a doctor from Colombia, actually from my city, and he was the division chief of pediatric infectious diseases. And I took the rotation just to fill a month that I needed, to do. And during that month working with him, I just got, in love with pediatric infectious diseases. And I did pediatrics to do infectious diseases. So I was not looking to do pediatrics and then, do infectious diseases. That was that month during the last year of medicine what actually made me change from adult GI to pediatric infectious diseases. So it's a complete different.
Yeah. Do you remember what it
different world.
was? Do you remember?
Coming from Colombia, I thought that a lot of the diseases in adults were, chronic or, they didn't have a good outcome because we didn't have the resources. When I came here, one of the rotations that I did, many of the rotations were adult, and I saw that, it was the same if it's pediatrics or not. The outcomes are not as good as in peds, and that we have to deal with, a lot of kind of behaviors that you're not unable to change in adults, and I didn't like that. A lot of chronic diseases that that if the adults didn't have the purpose to change, take the medications or change what they were doing, the outcomes were not good, so I didn't like that. So that's why I went more into peds and infectious diseases. I just in pediatric, which is different than adults, I like that every disease presents in a different way, so you never see the same thing. You can see the same disease presents in 10 different ways.
Talking about some specifics. So influenza, at least from a outpatient pediatric point of view, has been intense.
Mm-hmm.
What I've read has said maybe most severe season in 15 years or maybe more. What is the hospital experience or the pediatric infectious disease experience with influenza this year?
So we are seeing a lot of influenza and we're seeing a lot of complications after influenza. So we are being seeing a lot of, bacterial pneumonias after patients after kids have had influenza, which is a common thing that has been, described for many years. So it's really common to have increase of especially, pneumococcal pneumonia that correlates really well with the peaks of viral infections. Influenza and RSV are the two kind of main viruses that kind of correlate with the peaks of bacterial pneumonia. So we're seeing a lot. The vaccination rates hasn't been the best this year. So I think that explains a lot of the
Mm-hmm.
complicated influenza that we're seeing. Um, in the whole country, when you look at the statistic, we're still on a really high kind of hospitalizations or admissions to the hospital secondary to influenza. So it's still really high. The majority of the influenzas that are uncomplicated, we don't see because they come to the AD, they get diagnosed, and then obviously they get sent home. So we see more kind of the complex kind of influenza patients that develop, severe respiratory disease. Right now, I have on the service a kid that has developed myocarditis secondary to influenza A, that she's unfortunately was unvaccinated. And we're seeing, as I said, a lot of complicated pneumonias with empyemas and effusions with patients that had, flu-like illness, a couple of weeks prior. Some of them with diagnosis of influenza, some of them just with, flu-like,
Hmm.
flu-like illnesses.
What I'd seen with vaccination rates was in 2019, it was say 65%.
Mhm.
And it has been pretty sharp decrease to what you just said, right around 40%. That's a pretty dramatic
Yeah.
change in 5 years. How, if you were making a case or making a statement about why someone should get their flu vaccine, what do you say? I'm sure you get
Well,
asked this all the time.
yeah, but I think that a lot of the problem with the flu vaccination is a lot of kind of, myth around the vaccine or misinformation around the vaccine. Like thinking the vaccine doesn't protect you. Because I got the vaccine, I still got the flu. That's right. Or why I'm going to get vaccinated if the vaccine will give me the disease. So I think that those two things may a lot of people say, I'm not going to get it. And once the vaccine doesn't give you the disease, it's an inactivated vaccine. If you do the injectable one, and the other one is an attenuated, so you don't get flu from the vaccine. And the other thing is, there are vaccines that are made to kind of prevent the disease almost 100%, like smallpox, for example. Now it's eradicated. We don't see smallpox anymore. Or polio, we're like close to be eradicated, except unfortunately, there are some areas in the world that they don't get the vaccine. We still see sporadic cases of polio. But when you look with things like influenza vaccine, or COVID-19 is kind of the same example. You're not trying to avoid not having the disease. You're trying to avoid having the complicated disease. So you're trying to decrease the number of admissions to the hospital. You're trying to decrease these, kind of severe cases of influenza. And when you look at the vaccinations, through the years, most of the time it's about 50 to 60% efficacy on that, on preventing severe disease. But I think that people think, why am I going to get the vaccine if I'm going to still get the disease? But again, you're trying to decrease the severe disease. That's what you're trying to decrease with the vaccination. So I think if people get that information, they may change their mind and say, you know what, the vaccine does work.
Continue to talk about flu, but shift gears a little bit. Obviously, there's a lot about bird flu
Mhm.
and avian flu, bird flu, synonymous, same thing. As an infectious disease doctor, is that something you're worried about?
So we always worry about like new, either new viruses or when we have these ecological changes and we have viruses, from the wild that transmit to humans. Like an avian, flu will be one of those. Fortunately, so far has not been person-to-person transmission documented, and so far the transmission from the animals to human has been small, has been low.
So pause there for a second, because I do think this is something that a lot of people don't understand, that there's nothing really new about flu moving from an animal to humans. That's what these swine flu and other
So
things.
H1N1, which is
Yep.
swine flu, was one of those
Yep.
cases. When you have that small kind of mutation and change to went to humans. But in swine flu H1N1, that was
9 or
2009.
I think.
So the problem is in that one you start having person-to-person transmission. So far with this avian flu, we haven't had any person-to-person, so that decreases a little bit the transmission of the disease.
So
So far
spreading
as
among animals is one thing. If it spreads from animals to humans, that's
I
another.
think, and
But if it
then
changes,
when
and
you
it
have
can-
person-to-person, it's
right.
a totally different
Okay.
different thing.
That's
And that's
where
what
it gets
happened with
scary.
H1N1
Okay.
or swine flu. It went from the from the pig to the human, and then from human to human. So for this avian, so far we haven't seen any person-to-person transmission.
Do you think, given the way that it forms an immune response, the incubation period, that do you think that's about as good as it's going to get as far as statistic efficacy?
For flu, well, there is, they just approved a new vaccine that should come up next year, with with a higher dose, so that may help to have a better, better protection. The other thing that is going to come next year that has been already approved is that the use of the intranasal one as an outpatient that can be administered yourself, or
Right.
a caregiver can administer that. So Hopefully, that may increase the rates of immunization. If you don't have to go to a provider to get the vaccine, you
Hmm.
just can get it, get it
Walgreens or some store,
Walgreens
right? Yeah.
and do it actually yourself. So I think that the thing with flu vaccine is that it's different than the other vaccines that you know where you are dealing with. You produce the vaccine. What they do is usually between December or February, the FDA and the CDC and the World Health Organization, they meet and they start to see what type of viruses were circulating. And then they say, okay, based on this and based on how is the flu is traveling from the south to the north, we expect that the next season this will be the strains that we are going to see. And they try to match the vaccine based on that. So some years we have a really good match and we have a better protection. Some years we don't have as good as a match and we don't we have less less protection. But even with that, every year is between 50 to 60%. So uh, if you have a 60% chance to decrease severe disease, I think that that's a really good chance. The other thing especially during the winter, I think that is really important is if you are sick, not to go, and go to, to family reunions, and because that's the way that you spread also the disease. What we call a respiratory etiquette is really, really important. Wash your hands or cover your nose and things like that. We also prevent, the spread of the disease.
Shifting gears disease wise, RSV.
Mhm.
RSV, I mean, again, RSV is nothing new. It's been around, but it feels like it's getting a lot more publicity over the last 5 to 10 years. And is that something that you've seen uh, different this year than other years?
This year, we haven't seen a lot of severe disease from RSV, and so far, actually, the admission to the hospital are decreasing significantly for RSV. I think that the new things are the vaccines. So the new vaccine that is available right now, there is a new one that should be coming up. If not next year, in the following year, that seems to be even a little bit more potent than the new one. A lot of the RSV has to do with if you get RSV as an infant, the risk to develop, asthma, for example, and other complications as an older child. So I think that that's the important of trying to prevent RSV, or premature babies that gets it, they have a more higher risk to have chronic lung disease and asthma. But I think the new things are going to be the vaccines and also the adult vaccination. Unfortunately, the rate for RSV vaccines are really, really low. We're not even get to the 20% vaccination, for children so far.
Just clarifying for families that there's, as ways to protect kids, there's an RSV vaccine that mothers can get during pregnancy
Yes.
that will raise the antibodies that get passed across the
Mhm.
placenta,
Yeah.
protect
So
the
we
baby.
have, an adult vaccine that moms that are pregnant can get, and as you said, you will, by building immunity, produces antibodies, and that antibodies will, go to the baby and protects the baby. The same vaccine also are for adults,
Mhm.
65 and older. And then there is the kind of monoclonal vaccine, which is for the babies.
This is a borrowed protection. It's antibodies. It's not even stimulating an immune
Hmm.
response in the baby. Correct? It's just the antibodies that the baby gets that protect for 5 months, 6 months,
Yeah,
protect them their first
yeah,
winter.
yeah, correct. This is a different, so we call it vaccine, but it's technically not a vaccine. It's a monoclonal antibody. So they are kind of proteins that bind extremely, have what we call avidity. So they bind really strong. And what they do is they kind of block the fusion of the virus so it doesn't get in and it does not replicate. But again, because it's a monoclonal antibody, it doesn't last a long time like a vaccine does, which kind of stimulates your own immune system to create a response that has a memory. So when you get exposed later on to the bacteria, to the virus, your body kind of recognizes that and has already kind of mount a memory, so it kind of responds faster.
How do you personally handle uh, countering or responding to misinformation or even just the perhaps frustration of
Yeah.
the misinformation?
So we try to do a lot of education, and that's the part that I said different from adult and pediatrics. So I think as a pediatrician, even if you do any type of So specialization, a big part of pediatrics is educate, families, because to be able to get to the child, you have to educate the parents. So one of the things that we have a little bit more advantage is that we have in a way a little bit more time to sit with them in the office and talk to them. Our visits are usually a little bit longer. So we try just to explain in a really easy way, not using like really complex words and things like that. Why the important, how the vaccines are made, for example, in vaccination. Sometimes we even have to do it with medications. The safety profile. All the research behind that, what they are preventing. Um, but it's hard because nowadays with so much exposure to social media, it's not even the news challenge, it's the social media, and they believe that more than anybody.
Have you felt that change during the 20 years?
Yes, a lot. I feel that in the past, when a physician or a doctor or a nurse practitioner or a nurse, anybody in the health system talk to a family and say, I'm recommending this, they will say, this is the expert, so I'm taking the recommendation. Nowadays, we feel a lot of pushback on everything that we do, lab testing, medications, vaccinations, because, technology has brought a lot of good things, but at the same time has opened you know, a lot of information and misinformation. And a lot of people nowadays, they believe more, whatever they find on the internet that they actually what a professional is telling them. So it's becoming hard.
One of the things that can be hard for anyone to understand is why there are some vaccines that are so phenomenally effective, 95 plus percent effectiveness. And then there are others, like you mentioned, flu and COVID, that are significantly lower than that, even though
Mhm.
still beneficial. Is there an easy way to explain that?
Two things. So there are some of them, for example, flu and COVID-19. As I mentioned before, the virus changes, a lot. So the vaccine that we have this year maybe not the one that is going to cover for the next one. So that's why you have to get, repeated one. And with flu and COVID, you try to, or the companies, they try to predict what is going to be the strain. So if they don't predict the strain the right way, they don't have a good match, and they don't have a good match, then the protection kind of drops a little bit or not. The other part has to be with the immune, not just with the immune system. And so there are some vaccines that stimulates, just antibody production. Some of them stimulate better the memory, the memory part. Some of them have to do with, what type of adjuvant they have. It's really complex. For the measles, for example, you have to get two vaccines to be able to get above 90%. So if you get just one, then you don't get to that, to that. It has to be also as well with, how much of the population you immunize. So, for example, smallpox is not that the vaccine was 100%, that you were able to immunize such a big population that basically the virus couldn't circulate anymore, and then you eradicated the disease. So it's not just about just the vaccine as well as how much reach of the vaccination you get in the population.
What short list of tips would you give a family as a way to decrease their chances of getting the flu or any cold, actually?
So as a respiratory etiquette is so you have to try to hand washing. If you are going to a place that is somebody sick, not go. Use mask to protect yourself. The vaccination. um
Do you think there should be more mask utilization in homes to prevent intrafamilial spread?
no, in homes, I don't think so. I was meaning more if you have to go to a place that that somebody is sick with flu, and you have to go, then probably use the mask will help you, and doing hand washing. Uh, I think the mask in the house is unrealistic. I don't think anybody will be able to have the mask, 24 hours a day, inside the house. And we saw that with COVID-19. Um, but I think that, respiratory etiquette is important. I think that, hand washing is important. Vaccination is important. Be able to avoid it 100% is impossible.
Yeah, I mean, with flu vaccine, one of the things I try to tell families is I don't want to think about this every year. Just do it. It's
Hmm.
just something. It's the proverbial seatbelt. It decreases your chances.
Hmm.
It is Is it perfect? No. But are you better off getting it than not getting it? Every time, of
Hmm.
course.
Yeah.
And it's almost as opposed to each year, well, should I this year or shouldn't I this year?
Hmm.
It's really an exercise that's impossible to speculate and whatever, and really probably just one that should be just do it.
Yeah. Exactly. I think that you just do it every year, you get it. Um, and again, they have to understand one that they are not gonna get the disease from it, and second that you're looking is to avoid complications from the flu.
Yeah, and you've said it so many times. There is so much about this entire topic that is uh, speaks to the need for education, and the education has to happen in the context of relationships.
Hmm.
Relationships requires trust. I mean, it really does get back to some pretty basic human things
Hmm.
about medicine.
Yeah. I think that one of the difficult parts, as pediatrician, as you know, is the amount of patients that you have to see on a day. So it's difficult for these practices to be able to educate when you're obligated to see, 20, 30 patients in a day. It's just not enough. There is not enough time. So it has to be a way that the education can come from other places with the right information in the right way to say it. Because, in a busy day in a practice, it's just difficult you know, to fit it in.
It's an interesting point. This would be a whole nother episode, but it's almost as if um, the the world the world's methods of communicating have changed dramatically, and perhaps the world of medicine is lagging a little bit, still using the the ways we communicated in the
Yes.
1980s.
Yeah, completely. So that's why I said that we have to use these, kind of social media platforms to be able to communicate, and educate the people. And you don't see it. If I go to Instagram or if I go to X or whatever, I don't see anything education wise. Believe it or not, X for medicine is really good. So we have a big community on infectious diseases that they post new papers and they post really good questions, and so it's a good way to for to get kind of up to date on things. They
But you're
put out
communicating more with colleagues. That's more inside
inside
baseball. Yeah.
exactly,
Okay.
but you don't see anything education wise for families
Yeah.
there, and I think I think that we're lacking that part.
That's why we have Caring Well podcast.
Yeah.
That's what we're trying. Yeah. Segue to COVID. So it was a little over 4 years ago we were doing this. We were talking. It was right before the first vaccines were
Hmm.
coming out. We, we were excited. We're hopeful. The healthcare workers, gonna. A lot has changed in 4 years.
Yes.
Uh, so, without any specificity, what happened? What has happened with COVID, and what have we learned, and what went wrong? And
I think that we have learned a lot. At least now we know, we have rapid testing, we have molecular testing. When we do molecular testing, we know, what phase of the disease you are. You are like, acutely infected, or you are, in your past infection. We know how to protect ourselves. We know what is the right type of mask to use in the hospital. Now we have more better criteria, when to treat, how to treat, what medications to use. We have medication that we can do as an outpatient orally. We have IV medication that we can use to prevent severe disease. So if we have somebody that is a high risk and get exposed, we can do medications to prevent that person to get it. Vaccinations, RNA vaccines. I think that's just being able to have developed so quick an RNA vaccine is gonna open up a lot of new things for treatment. So I think that the experience, developing the vaccine for COVID-19 is going to open a lot of, new opportunities like for cancer, for example, with that, just with that technology. But again, it comes to the same problem of, and I think in COVID-19 is two things. One, misinformation. And second, I think that, we got, and I include myself, we got tired of it. That's right. We got tired to, every 6 months you have to get a new shot. So I think that I understand, why as a whole kind of community, people is a little bit reluctant to get it. Because it just was so many, information after new recommendations. So people just got exhausted.
if there's a metaphor of marriage between the medical community and the public you're serving, it feels like the marriage has been on the rocks since COVID.
Yes.
Um, do you think that gets better?
I think with time we'll get better. I think that little by little we have to kind of regain the trust, of the people. But again, the problem with when you have an epidemic like COVID-19 is that information is dynamic. So it's not that we made, I say like we mean like the public health system, the CDC of that we make the wrong decision. Is that we learn on the go. So that's why things change so much. But I think that if the information was probably given a little bit, more clear, then we shouldn't have, caused that much mistrust in the system, and things will be, a little bit different.
We've had a number of other diseases over the last year, 2 years, whether it's walking pneumonia, obviously a lot of press about norovirus. Um, any of these that you feel like are remarkable, worth mentioning to families?
Mycoplasma, I think that we should be coming down. We're not seeing as much mycoplasma, severe infection as we used to see maybe 6 months ago. The problem with mycoplasma is that it's not a reportable disease. So we don't have a really good kind of, sense of, how much we're seeing. So it's more what we do in the hospital. We see the testing positive, or we see patients with pneumonia that don't improve on conventional antibiotics. So we assume that is mycoplasma. We definitely in the whole countries, did see an increase of atypical pneumonia. No, mycoplasma, as you know, we call it walking pneumonia, and it's because it's not as severe as other pneumonias. Many of patients, adults or kids with mycoplasma, they recover on their own, without antibiotics. Um, but we are not seeing that much that we probably saw 4 6 months ago. So I think it's already on the coming down. The same thing happened with this, with group A strep, like strep pyogenes. So right there, maybe 2 3 years after COVID, we saw a lot of invasive disease secondary to strep. So not the regular strep throat, but truly, bacteremias, bad pneumonias, meningitis. That also is starting to come
And do you
down
think that was
significantly.
random variation, or you think that had something to do with COVID?
So we know that viruses, increase bacterial infection. Like for example, we know RSV and flu, as I mentioned, increases pneumococcal and staph pneumonias. So probably was some type of relation, with COVID maybe, or it was just bad luck and it just happened that we got increased rates of disease. Norovirus is not this, norovirus is a common virus. We call it the stomach flu, although it doesn't have to do anything with the flu.
Right,
But
right.
we call it stomach flu. It's really common during the winter. We see it every winter. It just happened that this year we're seeing more than usual. And this year has been mostly related to oysters that are being contaminated. So that's kind of have been kind of the trigger right now. And then from there it started, going from person to person. I think one thing with norovirus that maybe a lot of people doesn't know is that these alcohol, gels don't work. So you actually have to watch your hands. And then so we're used to in the hospital and even outside to use a lot of these alcohol gels instead of washing our hands. So for Nora doesn't help that much. So I think that putting that out there so people wash their hands after going to the bathroom may help. But it's not an uncommon virus. We know after rotavirus vaccine became available and rotavirus kind of went away. Norovirus became the most common viral disease to give you diarrhea illness. And it's really common, from November, October, all the way to April. So we still have several months to or weeks to go until start coming down. It's really important to avoid raw food. I
Mm.
wouldn't get any oyster right now, to be
Mm.
honest. And if you're gonna do it, you have to cook it about 165 Fahrenheit to be able to kill it. Really important hand washing. Extremely
We
important.
get questions sometimes just about my kid getting sick so much. Why is
Mhm.
my child being sick so much, getting sick so much? And then sometimes even the question, is there benefit to them being sick a lot early? Does it have some benefit later?
There are a couple of studies, really old studies, that have shown that the average kid that goes to daycare, the average kid, gets sick twice a month for an average of 10 days each illness. So that means that the average kid will be sick 20 days out of the 30 days of the month. And that lasts for about 2 years. Those same studies have looked at what happens if you take that kid out of daycare and you keep it at home in a bubble until they're ready to go to pre-K or kindergarten. And during that time, probably they never get sick unless they have siblings that bring things from the house. As soon as you put that kid on pre-K and kindergarten, that kid is gonna get sick twice a month for the same 10 days for the whole year because they haven't built that kind of, that kind of immunity. I think it becomes more a family decision whether or not they want have the kid getting sick when he's so young versus getting the kid a little bit older that is easier to handle. But that's the way that our immunity works. We call that clinical immunity. And that what happened with COVID. So COVID-19, a lot of kids that were older, 10, 11, 12 years old, that they were not getting sick as much because they already kind of got that clinical immunity after we put them, 2 years in a bubble, not going outside, not traveling, not going to family, reunions, not going to school. Those kids started getting sick again a lot. And it's because they lost that clinical immunity.
Hygiene hypothesis,
Mhm.
this idea that if you don't get exposed to stuff when you're young, it the immune system will gravitate towards allergic disease or autoimmune disease.
There is a lot of research about that. And it has actually been shown that yes, so you go more with like we call TH4, which is more kind of the allergy part. It's really interesting. But yes, it's been described.
Are you concerned about the potential reemergence? And it's really not even potential because it's happening a little bit, but
Mhm.
of vaccine preventable diseases?
Yeah, of course. So, right now, last week in Texas, there is, cases of measles in a community that because of religion reasons they don't get vaccinated. We have cases of polio, for example, now in Gaza and Afghanistan because lack of vaccinations. So yes, so because we have what is called herd immunity, that's right. But herd immunity is that if you vaccinate a large proportion of the population, if I get sick and I go to that population because that population is immune, they don't get the disease, and then the transmission stops there. But if I stop vaccinating, I lost that herd immunity. So if somebody gets sick and goes to that community that has low rates of vaccination, then they can spread the disease. So that's something that we saw with COVID when the rate of vaccination dropped from about 65 to almost 30% in some areas of the country, and we see that from time to time with measles, with varicella, with things like that.
You mentioned something, I think last time we talked, just about antibiotic stewardship.
Mhm.
Why should the average parent care about antibiotic stewardship? How does that affect them?
What we do in the hospital with antibiotics reflects on the community. So if we do, for example, and in the community as well, in the hospital. So if we do a lot of unnecessary antibiotics, either the medication that we're choosing, what we call like increased broad spectrum. So instead of just trying to treat one single thing, we use an antibiotic that covers 20 different
Just to be
bacteria
safe.
just to be safe.
Right.
That's right. Or instead of doing 5 days of treatment, I want to be safe and I'm going to do 15. Okay. So that makes what is called pressure on the bacteria. And the bacteria, what it does, it becomes smart and becomes resistant. And many of these bacteria are able to jump from one person to other person, or the gene that confers the resistance jumps from one bacteria to other bacteria and another person, and then we ended up creating is resistant bacteria. So when somebody gets sick and get to the hospital, we don't have many antibiotics to use. So now, for example, we're seeing a lot of kids that develop, urinary tract infection, which in the past we do an oral medication, you treat them, they go home, they don't even have to come to the hospital. But now we're seeing, completely healthy kids that have never put food on the hospital for any reason. They ended up having infections with bacteria that we don't have any oral medication that we can use. So those kids ended up being admitted to the hospital, get a line to be, placed. They either have to stay in the hospital 5 to 7 days to be able to get the medication that they require, or they need to get a special line that they can go home, and the parents have to administer the medication at home because we don't have any oral, medications to give them.
Do you feel
So
like the trend line is increasing resistance? Is
Yes.
that okay?
So that's what. So when we do antibiotic stewardship, we look at two things. One, obviously, reducing cost. But in antibiotic, there is not a lot of cost. Antibiotics usually are kind of cheap. So what we really want to do is decrease resistance. And by decreasing resistance, we decrease the medications that we have to use. We decrease the duration of therapy that we have to use.
I've
That's kind of the
heard
goal.
that antibiotic development there's not a lot going on with that.
No, there is not a lot, and the reason again is financial reasons. Pharmaceutical companies don't make a lot of money on antibiotics. So for a long, long time, we didn't have any medication available until there was a push from the CDC, specifically from gram negative that were resistant. So in the last, probably 5 years, we do have new medications available for gram negatives, but that's it. There are not much, there are not many. So to the point that sometimes we have to use actually really all medications to treat infections that we haven't used in a long time, like chloramphenicol or polymyxins and things like that. That we used like 34 years ago, because the new medications are resistant. The new thing that we're working right now is in something that's called diagnostic stewardship. And it's the same that we talked at the beginning, is to try to limit the tests that we need. So, instead of doing, labs every day in the hospital, we just do it when we think that the patient needs them. Instead of, you have someone that is complaining of, I don't know, hip pain. Instead of, doing a CT from the head to the toe, I just kind of concentrate on that area, or try to, instead of ordering, 40 x-rays, maybe in this case it's better just to just do this ultrasound. Or so that's the new thing.
Is there anything you wish general pediatricians knew, did more, did less as a pediatric infectious disease doctor?
Definitely antibiotics. I think that,
You're saying do less antibiotics.
do less
Right.
antibiotics. And I think that is, it's difficult, because when you look at the studies, there are really good studies showing that if a family comes to a pediatrician, specifically for pediatrics, to a pediatrician office, and the family doesn't leave the office with a prescription for antibiotics, that doctor gets a less
Favorable review.
favorable review.
Hmm.
So that's hard on the pediatrician. That's right, because nowadays, again, with social media, we're all based on these, reviews. Google review and review here, review there. So those studies have shown that if the patient doesn't leave with a prescription for antibiotic, then they will rate the physician lower. Um, and so in a way, I feel that sometimes the pediatricians, they feel obligated to do something, because of, they want the patient to be satisfied, with the visit. But I think that, one thing the pediatricians can do is, do duration of therapy.
Shorter durations.
Shorter duration.
Yeah.
So we're working right now in the hospital to do, you know really, really short duration of treatment. So, in the past, for example, infections in the urine, with like severe complicated infection in the urine, we used to do like 3 weeks of therapy. Right now, we're 5 to 7 days. Pneumonias, for example, we are 5 days of treatment.
With equally good outcomes.
Yeah, complicated pneumonias, that develop that, fluid in the lungs. We used to do 14 days. Now we do 7 days, and we don't have any relapses, or we don't have any readmissions. So it works. And by decreasing that duration of therapy, we decrease, a lot of that antibiotic resistance that can happen in the future.
Do you think you parent differently because you're a pediatric infectious disease doctor? And I guess the follow-up question is, what could every other parent learn about parenting from a pediatric infectious disease doctor?
So, if I understand the question well, do you think that the parents will listen more to us because we are?
No, you as a parent.
Uh-huh.
So is there something, because of your knowledge, because of your field, that the way you parent your children, that you think others should adopt?
I'm way, way more relaxed than somebody else. But I have my wife, on the other hand, that is not.
Okay.
So I have that balance.
Balance, yeah.
But yeah, so we tend to be, it can go both ways. I can be more relaxed, but at the same time, I can get, in some cases, worried,
Because you've seen stuff.
Exactly. I have seen stuff. So, if I have a patient that, in the hospital comes with, I don't know, fever for 10 days, I'm going to think this is infectious, viral infection. But if it's my own kid, I may think, maybe it's leukemia, maybe it's, because I have seen it. But I'm really kind of, I'm really relaxed, but I don't make any decisions for them at all. I stay, completely out of it. So, I unless I'm traveling and it's an emergency and I have to do it, I prescribe, I for them. Other than that, I try you know, not to make decisions under care because I don't want to be guilty that I make the wrong
Yeah, you're not
decision, the wrong
objective. Yeah.
diagnosis. So I try to keep it really, really objective.
If you had a magic wand or if you were state surgeon general for a day or a month, what would you love to see happen that would benefit kids? It can be something infectious disease or not.
Well, I think that family education is has to be a priority in many things. Prevent diseases, vaccination, hygiene, nutrition. I think that we lack a lot of education.
Hmm.
Uh, you know,
And you're saying education from the medical provider to the family,
to
better
medical
ways
provider
to
to the
educate.
family. Yeah, and I think that has to be done in a way that is easy to understand. We as physicians sometimes we talk in this language that is impossible to for families to understand. So I have to be in a way that they get that gets to them.
If you weren't a pediatric infectious disease doctor, and maybe you said you were leaning towards adult GI, maybe if you weren't in medicine at all, what do you think you'd be doing?
So when I was growing up, when I was a child, I was between engineering or medicine. So I think if I'm not on medicine, I probably will do some type of engineering. I love math. But if medicine, I have had these how do you say philosophical, conversations with Federico, my partner, all the time, and we go back again to the same thing. We don't see either of us see each other doing something different than
If you're in
infectious
medicine,
diseases.
your PEDS ID.
Yeah, and we go to everything, the good things, the bad things, from the time that consumes, from financially, par, from for everything, and we ended up going always to pediatric infectious diseases. So I don't see myself in medicine doing something else than this. But if it was not medicine, probably something with engineering.
Do you find uh, the cases you see because of travel and we are an international city? Do you find the cases you see here different than maybe the typical city of our size in America? And if so, are there just remarkably rare things that you see?
Because of our location, we see kind of amoeba, that other parts of the country don't see as much. So Texas and Florida are kind of the two biggest states, for amoebic encephalitis, disease. So we have seen couple of cases of that. Compared with other parts of the country, then we see more kind of tropical diseases because of the traveling, like dengue, chikungunya, malaria that other places don't see. Um, we see, probably things that other, like Lyme disease, because we see, people coming from the Northeast, and we have seen, um, you know, that's that's kind of the things because being such a touristic area in Florida, we see a lot of those things. I remember I did fellowship in a really big center, and I remember when I came to Orlando, I said, if I'm coming from this big place, I probably have seen everything, and no, I have seen things here that I have never you know seen or imagined that I was going to see. But I think the rare cases probably amoeba is one of the rare cases that we see in Florida that other states don't see as much.
Are you worried about Orapucci
The
fever?
alopecia fever. So
Yeah.
we got two kids that we tested for, and they came back negative.
Hmm.
So, but we was on the differential.
Well, it makes you think of no-see-ums in a whole different way.
Yeah. So
Is it because it's mosquitoes
it's
and
mosquito.
potentially
It's mosquito. There's they were coming from vacation from Cuba.
Okay.
And Cuba was at that point was big on it.
Hmm.
So we tested for it, but no, it
Okay.
was negative.
Not yet. All right.
So yeah, so we haven't seen it, although we have tests for it.
I've got a few rapid fire questions, but I have one last question before that. What do you think you and I would be or will be discussing a decade from now about infectious disease? What's the future of pediatric infectious disease?
So, well, I think that we're going to be talking about artificial intelligence in medicine in general, and specifically in infectious diseases.
Diagnosis?
Try to find tools that help us make diagnosis faster. So when we have these syndromes, for example, that we have to try to look in different ways, what is causing it. It has to be a way that we can put all that in a tool that help us, kind of narrow that differential diagnosis. So I think a couple of years from now, artificial intelligence is gonna be huge. Um, I think that we're gonna be talking about new diagnostic testing, like rapid testing, molecular testing. There are a lot of on metagenomics right now, next generation sequencing, you know, um, blood cultures, instead of taking 2 days to know what it is, in a matter of an hour or two. I think that that's gonna be the future. I'm sure that we're gonna have another new virus coming up, or new increase in some known disease. But I think the future for us is going to be, artificial intelligence tools. I don't think that they're going to replace us. I think that we have to learn how to use them, to provide better care. And I think diagnostic testing is going to be huge.
All right, you ready? Some rapid
I'm ready.
rapid questions. All right, what's a better infectious disease song? Hot Blooded by Foreigner or Toxic by Britney Spears? Or you may not know either one.
I may know. I know Toxic by Burns, but I have no idea what the song says.
Yeah, okay. Hot Blooded, it's a classic. That may have been before you were over here. So, all right, would you rather have a tick bite or a cat scratch?
Oh no, a cat scratch.
Yeah.
Oh yes.
Tick bites you don't like. You're worried about that.
No, yeah, tularemia and
Too many diseases.
Yeah.
Right?
Bartonella, believe it or not, is self-limited. Most of the time goes away without treatment. But rickettsia and tularemia and no, that one no.
Too many tick. All right. What animal that people have as a pet do you, as an infectious disease doctor, think no one should ever have as a pet?
Komodo dragon, I guess.
Komodo dragon, right? What's more likely in the next 3 years, another pandemic or the Magic win an NBA championship?
Another pandemic, probably.
Oh, man. The last question. Who is my favorite Colombian superstar after Shakira?
Yours?
Yeah. It's Dr. Alejandro Jordan.
Oh, thank you so much.
I've told you that before. You're the best. You care for so many kids and families, and they have no idea. You collaborate with other specialists, and you help us so many times. I feel like you're such a hidden gem in this community as far as caring well for families. And so I'm grateful. I think our community, those that know you, are so grateful, and those that don't will be. So thank you for joining us.
Thank you so much. It was great.